So good afternoon. I'm Aleah. Thank you so much to your dean, Dr. Paul Irwin, and the amazing team that helped get me here today. I'm ecstatic to be here, and it's my great pleasure to talk to you about a healthcare delivery model, medical legal partnership that I'm very, very passionate about. So in terms of how I'll spend the hour with you today, I'm going to start off with just a tad bit about my experience under the model. Then I'll share with you a personal story about a family who received care under the model. And then we'll get into the slides properly. I hope to leave time for questions, comments, and informal discussion. I think that helps to enrich what we've heard and learned. But before I get started, who in the room has worked under, or is familiar with this model, medical legal partnership? Anybody? Awesome. So one. So we can explore it together today. So I was first introduced to this model my very first week of my very first year in law school. And I was intrigued when I heard about it because to me it was a great marriage between my background in public health and my love for the law. And I was fortunate enough to receive another opportunity to practice under this model once I was done with law school. And so as was mentioned in my bio, I was the attorney on site at Bellevue Hospital and their medical legal partnership, and I served the Department of Child and Adolescent Psychiatry. And that was a multi-layered in terms of programs department with inpatient units, an outpatient unit, partial hospital, home-based crisis intervention. So it was a large department that served a large patient population, and Bellevue, for those who aren't familiar, is the largest public hospital in New York City. So needless to say, it was a very busy department, and we were a very busy clinic. What I learned from my time there is that if we are servicing families that have cyclic, compounded, complex problems, we need to be deliberate in how we approach care and how we assess and address their problems. And so I will tell you the story of one particular family that was referred to me by Bellevue's clinical team and how we served this family and provided care underneath this model. So the referral came in after the clinic was probably just about a year old, and it was referred by the clinical team from one of the inpatient units. And they said that they had a family that was in grave need of legal care, legal representation. And so when I first met the family was in crisis. Just to highlight a few of the problems that the family was enduring, they had 3 daughters, and the middle daughter had special needs. She was being sent to the hospital via ambulance. No one could ascertain what the problem was, what was her diagnosis. She could no longer take public transportation because she had these frequent episodes that caused her to have to get off of the train. At that point, mom was stuck to the bus because she could more readily get off when the bus stopped if something were to occur. Episodes walking down the sidewalk, it was just unbearable. Mom was unable to hang on to her job due to her child that was in crisis. When that happened, you can foresee they were evicted. Once they were evicted, they landed in a shelter, which had horrific conditions, and that made no accommodation for the child's disability. From there, they ran into issues with their government benefits. The child was failing in school because she missed so much and she wasn't learning while she was in the classroom. When mom tried to advocate for her daughter at the school, school officials actually opened up a child welfare case, called in a case on her in retaliation. So that nightmare began. So this is how the family presented on the afternoon where she walked through the door to see me. And once we ascertained all of these problems based off of the referral from the clinical team, we began to triage and figure out what we could do for the family in terms of legal care, legal representation. And so I'll just highlight some of the outcomes from our representation. In terms of the housing issue, it took a while, but we were able to write letters of support to get the family out of the shelter and into a multi-bedroom apartment, which is nothing short of miraculous in New York, but that was a team effort with letters coming in from not only the doctors, but also from our office. While they were in the shelter, we wrote letters to caseworkers and made calls for reasonable accommodation and for them to have an understanding of the disability that the child lived with. In terms of the education case, we brought a due process case under federal law and got a compensatory award for the child. That allowed us to get a private set of evaluations from the NYU Child Study Center. We got a compensatory award that got the child into a new, smaller, more therapeutic school that met her needs. She was newly diagnosed with autism, and so we were able to get training for the parents at NYU to learn about what it means. I'm sorry, it's an award that allows for services for a child if they win their case under federal law. So it's not an actual money award, but it's an award where the department pays for services. Thanks for the question. So speech language services, because she was diagnosed with a severe speech impairment, social skills training so that she could better relate to her peers and to the people in her community. For the government benefits piece, we had to go to hearing to get the benefits straightened out. And finally, for the child welfare case, we worked closely with the caseworkers and the managers from that institution to get the case closed swiftly, get the investigation stopped due to evidence and resources that we had because we were representing the child. What is more is that the local agency that was discriminating against the parent, we got that entity investigated because they had a pattern of retaliatory, discriminatory behavior to parents who were trying to assert their rights on behalf of their children. So this is just one example of how this model can work with social workers, doctors, lawyers, other professionals working together on behalf of a family to stabilize a household. Because if we're going to reach in and try to cover a child in a home, we also have to address the entire household. So a holistic approach to stabilizing households, I think, is the way to go when we talk about advocating for children who live in poverty. So at the end of our representation and our time together over the course of several years, I asked the mother, how would she describe the care she received? How would she describe this model? And in one word, she said, hope. It gave her hope. And when I talked to other parents, their response also incorporated the word hope. And so that's how we come to integrating lawyers and offering hope through medical legal partnership. And I think it's the lens that we should view this model as we talk about it more today. Because so critical in the work that we do on behalf of families is the power of hope. And so we'll keep that in mind as we move forward. But first, I just want to offer some context in terms of who we're serving. So this model has been shown effective and functions to serve families who live in poverty. And so you all are in public health and are no stranger to statistics. And so you're probably familiar with the fact that about 1 in every 5 children in this country lives in poverty, and that children are overrepresented among this country's poor population. Children represent 23% of the population, but make up 32% of all people who live in poverty. So there's an overrepresentation, especially of children among our nation's poor. In terms of Alabama specifically, I was able to pull some stats and found that recent numbers indicate that 27% of children live in poverty, and about 13% of children in Alabama live in extreme poverty. So, to set the contextual backdrop, this is something that might be effective as we look to approach poverty in a way that's interdisciplinary and holistic. So as we begin to talk about the model, we should set the stage in terms of 3 realms of professions that deal with social determinants of health, which is, I'm sure, a term you all have heard of. So we have healthcare, which treats illness. We have legal aid, which ensures that access to benefits And services is enforced by law, so that justice is sought. And then we have public health, which tracks disease on a population level, but also addresses laws and education. But most of the time, these three sectors operate in silos and don't operate in a way that's collaborative. And so what you might have in that siloed example is you might have a well-intentioned clinician that is doing his or her job and treating the patient effectively. And so here the clinician says, great, that ear's better, that ear infection is gone. Is there anything else I can help you with? And then we have a parent who's weighed down with rent and school and heat and food and income. And they're dealing with all these social factors that might cause stress, but also implicate health. And so we offer medical legal partnership as a way to help clinicians operate in their expertise area, but bring in legal professionals to help with some of these other problems that the family might be facing. So let's get into medical legal partnership. So technically, medical legal partnership is an intervention where legal and healthcare professionals collaborate to help patients resolve environmental or social factors or hazards that contribute or exacerbate existing health disparities, but are rooted in terms of a remedy in civil law. So, more simply, medical legal partnership is a healthcare delivery model where lawyers are embedded or integrated into healthcare teams to help identify, combat, and prevent social problems or health-harming legal needs. So a health-harming legal need, simply, that's a type of social determinant of health. It's a social problem that adversely affects a person's health or access to care that is better remedied from a dual approach or multifaceted approach rather than just seeking to address the problem through healthcare services alone. So just a bit of terminology. In terms of how this model has been proliferated throughout the country, we can see here that MLPs are almost in every state. The state where I was coming from, New York, has a lot, along with other states that have numerous MLPs. If we take a look at Alabama specifically, you can see it shaded where it says it has 1 to 3 MLPs. I checked with the National Center for Medical Legal Partnership and was told that these aren't true MLPs in terms of an integrated model that I'm going to present today. What it is a relationship between the VA hospital and a legal entity that exists that they're counting as an MLP, but it's not a true integrated partnership as I'm going to present to you today. So just wanted to clarify about Alabama right now. But that just shows you how the model kind of has spread throughout the country since its inception. So MLP was born, I think, in the early 1980s in Boston, MLP Boston, through their pediatrics department, but the model has spread and has expanded to serve several client populations. So here's a slide from the National Center from 2016, and it just identifies the number and type of entity that's involved with this model, just to give you an idea. Notably, health centers, federally qualified health centers, have become strong partners under the model. Speaking of models, so the model is emerging, and the model targets the intervention to certain populations. So the model can be tailored to address the population that you want in the way that you want. So in general, as we said, it's built and works effectively to serve people who live in poverty, but it can also be tailored to address specialized populations. The example in New York that I worked under targeted children who live with disabilities, trauma, and other psychiatric needs, but it's also been used to treat children with lead poisoning, cancer patients, veterans, you name it. So the model is malleable in that you can tailor it to certain populations. Also, when you build an MLP, people are thinking structurally in terms of sustainability, and so they've incorporated primary care associations, which is the umbrella organization that works to support federally qualified health centers in their states. excuse me. And also it integrates large healthcare systems, thinking long-term about sustainability. So these are some of the things that can be thought of when you're talking about introducing the model to service patient populations. So in terms of the overarching approach, ideally, this is how the partnership works. Legal professionals train members of the clinical team to identify social problems, legal problems with social roots. In turn, the clinical team members issue spot legal problems as they treat their patients. This, in turn, can transform clinical practice and policy, which can ultimately improve population health. So you're thinking about, individual patient level interventions that can forge pathways into policy intervention on a systemic level to improve population health. So if a member of a clinical team is seeing the same type of problem, right, with every family or with a lot of families, that's a pattern that can be brought up, and then they can work collaboratively with the legal team to work to advocate for policy change or to help make a community healthier. Okay, so now the staple of the model is the integration of lawyers onto the clinical team, and so that's what I want to get into next. The concept is called legal care, and I love that phrase because I do care. We do care. And I think that the healthcare team can provide healthcare, and the lawyers can come in and concurrently provide legal care. So let's get into that a bit. So legal care is the full spectrum of interventions that really work to identify and address legal needs for the patients that they serve. I use patients and clients interchangeably. Patient, clients, we're talking about the people. We're talking about the people that receive services under the model. So again, we talk about the provider training. And the training really can be more than just training on how to spot the legal issue. I also train the clinical team on the scope of our legal services, which we'll get into momentarily. We taught the clinical team how to refer in a way that's effective, in addition to how to spot the legal issues. We also did trainings on basic know your rights topics that were coming up in the news and coming up for these families. And so I think I found the more our clinical team knew, the better they could identify, spot, and refer families for legal care. So in addition to training and the legal screening of patients, triage and consultations with clinicians was really key. So once we received a referral, obviously we would assess what needed to be addressed first, what we could help with, what we couldn't help with, but then we stayed in constant communication with our clinical partners so that we could help the family along, so that whatever we did for them on the legal side helped them to better absorb whatever medical treatment they were providing on the healthcare side. And we also mentioned how this can transform the way healthcare is administered in terms of policy, and eventually can lead to changes to local, state, or federal policies, in addition to regulations. So in short, MLP attorneys help resolve patient problems through legal representation and advocacy. We consult ongoing with members of the clinical team, and we leverage our expertise to help advance state and local policies when the situation and opportunity arises. For those of you who are more visual, let's put it a different way. So we train the medical providers on legal problems. Once that happens, they can issue spot or identify problems within the patient population. They then can contact a family who they think might benefit from legal intervention and refer them to legal. It's completely voluntary. It's not a mandate. It's another service that's offered at a single point of care. And then from there, we follow up with the medical providers in an effort to close the communication loop once we receive the referral. So what does that look like? Okay, what does that look like? We've made contact with the family, and they're coming in to see us on Monday. Or we just met with the family, and we're going to help them with this particular problem. Or we can't reach the family, is there another number that you have for them, or another loved one, neighbor that can, reach the family because we can't get a hold of them? I mean, it can present in many different ways, but the point is that the communication is ongoing until we're able to bring the family in to our care and they retain us as their advocates. So this is sort of like the logistical flow of legal care, but the point is to have hands on the family at all times through all points in the referral cycle, and to complete the communication circle at the end. So what kinds of problems did we help with? There's a helpful mnemonic that I really like, and it's called I help. And similar to legal care, I like I help because I do like to help. And it's a great way to remember and to have our clinician family remember sort of the scope of services that we provided. So the I and I help is for income. You can think of income insecurity and everything that goes into that, government benefits, et cetera. And also insurance, housing and utilities, employment and education, legal status, and personal and family stability. So I'll say a little bit about how that manifests under the model we had, just to give you an idea of how this might function. So in terms of income and supports, because we represented children who had disabilities, there was a continuous pipeline of cases that was ripe in terms of disability benefits being denied on initial applications, either because the parent just didn't have a good grasp of the medical condition and how to convey that in the initial application, or because there weren't enough evidentiary documents to support the initial application. So a lot of families that we met had been denied at the outset, although their children lived sometimes with very severe conditions. So advocacy in Social Security, SSI hearings, or disability hearings was a big part of our practice from beginning to the time that I departed. Insurance can also manifest in terms of Medicaid denials or access to care being shut off, et cetera. So that's things that the legal team can help with. Housing and utilities, I mean, you can think of an array of examples how we might be helpful, but one thing that I really started doing was to write letters of support to providers of housing, requesting reasonable accommodations for families with children who live with disabilities. I had kids in wheelchairs, children who could not ride in crowded elevators, as you can imagine in the city, so they needed units on the first level, access to bathrooms, et cetera. So anything that required a reasonable accommodation, a child who needed their own room and their own space because of a mental health condition, we wrote those types of letters to try to get accommodations and housing. Also, we wrote letters to try to have all care services in one location, like a hub of services. So it's unhelpful if a family lives across town and the school is on this side and services are all over here, all over the place. So we tried to get housing closer to services, housing closer to care, housing closer to the school, really, which made a huge difference for families which were communicating to us that it's extremely difficult to transport their child all over, especially if the child just has a problem traveling on public transportation or riding long distances in a car to begin with. So those types of letters of support and demand letters were critical. Employment and education, obviously, special education issues and school suspensions were huge for us in terms of advocacy in that area. Ensuring due process was upheld or preserved. But also employment issues. Some of the parents reported workplace justice issues, and that was critical and relates back to income insecurity and to housing. So all these problems are interrelated, and again, we felt like we had to take a holistic approach in order to address everything that was happening for a family at the same time. Legal status issues came up, and also personal and family stability. So I've given you some examples, but this slide hopefully gives you some more examples of how lawyers can help across these different I help categories. In terms of legal status, asylum applications was something that we definitely saw. Getting parents' rights over children who maybe join them later and allowing them to make decisions about their education, et cetera, was something that came up. And finally, on personal and family stability, a lot of the children and families that we served were dealing with some sort of trauma. They were fleeing some sort of trauma. And so, child support, child custody came up often, as well as what I mentioned in the initial story that I told, child welfare cases being opened. And we saw it time and time again in retaliation for a parent who was finally asserting his or her rights after they learned them on behalf of their child. And that was some of the most distressing problems for the child, because as you know, sometimes once those cases are opened, a nightmare ensues. And so we were very active in our advocacy, working with the caseworkers to let them know exactly what the parent has done, is doing, and how certain systems have failed this child and family, and presenting the necessary evidence to get those investigations closed so that the parent can move on to the next problem. So these are some of the ways lawyers can help across the I help categories, and hopefully it gives you a better idea of what exactly is included within legal care. Okay, so I'm going to try to review everything we just went over just to lock it in for you so we can go ahead and move on. I thought a quote from Dr. King was appropriate, given that we will be celebrating his life coming up in the next few days. So the components of an MLP. So we already know there's a lawyer in residence. There's a lawyer on site. I really believe in a highly integrated model because I think presence is important. So even though it was difficult on a week-to-week basis, I was actually present at the hospital 2 full days a week, which might not sound like a lot, but imagine being away from your home base 2 full days a week and off-site. But we thought that was critical in terms of FaceTime with the families, accessibility for the clinicians, and also just for us too to benefit and be able to consult and really absorb the expertise of the clinical team. A formal agreement between the health and legal organizations, a written agreement. Oftentimes this is a memorandum of understanding, an MOU, but it's some sort of document that lays out the logistics, how things will be set up, and what will be agreed upon. That's important to have. Knowing who you're serving, your target patient population, screening patients for legal needs. We talked about that. After the clinical team is trained, they do screen. Legal staffing, being staffed out appropriately to meet the demand. We know that there's a great demand for services among families and children who live in poverty, especially when the legal services being offered are free. So just thinking about legal staffing, continued training on the social determinants of health, information sharing, resources, etc. So these are some of the major constructs or components of this particular model, and hopefully you're familiar with those now. Okay, so now I want to talk about the benefits of the model to the different folks that are involved. And I'll start with the actual patients. So studies show that patients with chronic illnesses are admitted to the hospital less frequently, because hopefully they become stabilized at some point under the model. Patients more commonly are compliant with their medications, which I imagine is a great thing. And people report less stress. And hopefully it's because that holistic approach is really helping to solve some of their problems, or at least lessen some of the pressures that are related to some of their problems. Also, studies show that less money is spent on healthcare services, and that clinical services are more frequently reimbursed. In terms of the clinical team, here's a few things to touch upon. So the National Center for Medical Legal Partnership, which is headquartered in DC at the George Washington University, did a survey in 2016 that surveyed MLP programs throughout the country. We actually participated in that survey, and the results showed that 86% of clinicians reported improved health outcomes among their patients. 64% reported improved patient compliance with medical treatment. We just sort of kind of touched on that in a small way in terms of medications. And 38% reported an improved ability to perform at the top of their license, meaning that they're focusing on doing things that falls within their expertise, while other members of the interdisciplinary team are doing things within their areas of expertise, and everyone operates hopefully in a way that's more effective and efficient. Along with that, it's been demonstrated that there's increased clinical staff satisfaction because time is saved and people can concentrate on things that are definitely within their lane. And also there's improved efficacy in screening patients' legal problems. And the last one is something, actually the last two is something that I really saw with the various clinical teams in the Department of Child Psych that I served at Bellevue. In terms of improved efficacy and issue spotting problems among the family, we saw that over time. The clinical team was already, really committed and dedicated, passionate, and incredibly sharp, but we saw over time that they became more sure of what they were referring. So at first it was like, hey, Aleah, got this family for you. I think they're having a housing issue and some other problems with income. Is this a case that you could take? Let me know if it's okay. But then over time it was like, hey, Aleah, got this family and the issues are X, Y, and Z. And, let me know when you make contact with the family. So their efficacy and their own ability to spot an issue that was ripe for legal intervention increased over time. And that only streamlined the whole process for everyone involved. In terms of benefits for lawyers, I'll just make a threshold statement and say I can't imagine practicing law outside of this model because of how it benefits me as a legal advocate in terms of the work I do for patient clients. First and foremost, it's so much easier to access relevant health records and documents when you're working within a clinical team under a memorandum of understanding that grants easier flow to information. And that was so critical as I was preparing for different proceedings or hearings or just general negotiations on behalf of these families in the community. Also, it allowed me to have ongoing conversations with professionals with expertise that I did not have. So I was able to go and talk to the psychiatrists, to the psychologists, to the social workers about services, diagnosis, prognosis, and specific conditions that I didn't have a good understanding about. For example, I had an epiphany one day that when I heard one of the attending physicians during rounds, I rounded with the clinical team, say that a child with a severe speech impairment is going to act out behaviorally in the classroom, because they can't express their frustration or because they can't express when they have a question or when they're not learning. And so what happens is that they act out their frustration. That might seem basic, but that blew me away. And I used it in hearing. I used it in my arguments and legal briefs and documents. And it's just so helpful to be around other professionals that have a different expertise because it grows your knowledge. And I think the same benefit can be had for students who work under the model. So just the accessibility to their opinions and their expertise is critical for my legal representation, and I think only made it more effective. The third bullet also is incredibly critical, and that's the benefit of receiving a warm handoff from the clinical team. So not everybody likes lawyers, get that. Not everybody trusts lawyers, get that. And I think that some people generally feel better about their doctor or their clinician or the social worker who helps them than an attorney that they've never met. And so I can't tell you the value of being on site and having a member of the clinical team literally walk the family down the hall and introduce them to me as someone who's trying to help, what that meant for getting our relationship off on the right foot. And so the handoff from a trusted clinical partner, I think, was critical for getting a family to open up and start to share some of their story. Respect for person and a listening ear also helps. But I think the warm handoff was critical. Also, access to clients at their medical home. It goes back to the same amount of comfort and trust. And if someone knows how to get to a place, is comfortable getting to a place, and has been treated adequately in that space, to meet them there rather than at a legal office or a place where they're unfamiliar can be helpful. especially for families, who might not be English speaking, or families who just might not have had a good experience with other systems that have failed them time and time again, as it regards their child or their life in general. So I think accessing the people where they currently are receiving services is also a major benefit for me as a legal advocate. And finally, we talked about how this model helps streamline the intake process and the case screening process. So when you have a sharp clinical team who's trained to spot legal problems, what you have is a pipeline of ripe cases at the ready for you to take, and the initial intake process, which can be arduous and time consuming, is streamlined in a much better way if I have a jumping off point of issues that I'm looking for in addition to other problems that I screen for. So hopefully that makes sense in terms of benefits for the clinical team as well as benefits for the legal advocates involved. But also, more largely, there's benefits for the community. We've talked about identifying patterns that are adverse to health and are definitely needs that patients have. This model can help reveal opportunities to advance systemic policy, which we've talked about, and work to ultimately improve population health. And this slide I added for today, but it's MLP and public health students or public health professionals. So when I was working under the model in Chicago in law school, we actually had public health students that we sat next to and worked with, which I thought was awesome because my background's in public health. But public health students can receive benefits and have a role under this model for sure. So don't be fooled by the name. To me, public health is incorporated with the health and medical side. And so students and professionals can receive training on this interdisciplinary model alongside other young career professionals and students, which I think is an amazing experience. I actually still keep in touch with some of the students I worked with in New York, and it's awesome to see how this model has sort of shaped their careers in terms of even opportunities that they were looking for once they had this experience under the model. Also, students can screen for social determinants of health among the patient-client population, identify those harmful patterns that we said might occur, create survey tools for research and evaluation purposes, which is so needed because oftentimes we don't always have time to be thinking about evaluation, especially if you're a small team and you're just trying to meet the need. Having students and professionals with the capacity to help with that work is critical. Participating in legal and public policy advocacy, I think, is important and really hopefully the bedrock of what can be produced. Exploring laws that address the relationship between implicit bias and the social context of health disparities, and finally providing formal comment on proposed health rules and regulations, which that opportunity does come up from time to time, and it's amazing when it does. So this is just an idea of how public health students and professionals can be involved in the critical work of the model in a major way that I think is very needed because, again, other folks in the model are focused on what they're focused on, and so there is a place and space for public health students and professionals. Quickly, just common forms of funding. You might imagine that money is needed to make this happen. And so among healthcare organizations with MLPs, just under 40% contribute funding from the operating budget. But obviously, external grants, foundation monies, charitable donations are common to keep this model afloat. And so here are some resources that I just wanted to highlight for you. I don't know if the slides will be made available later, but the number one resource I wanted to point out was the National Center for Medical Legal Partnership. So they have a website. If you can't take this information down, you can just Google and it'll bring you right to it. But they have compiled a nice bank of peer-reviewed journal articles, case stories, case studies, and other related resources. So if you're interested, I highly encourage you to go to their website. The other things on the resource slide are just different things that I have pulled from to sort of bring to your attention. Actually, the lead poisoning in children in Chicago, that was the MLP that I had the good fortune of learning about the model under. It was run out of the Loyola University's School of Law's, the legal clinic there. And so that's a good one to read. But there's other related articles that you can take a look at in your spare time.